So I'm really excited to talk about really our team and approach to improving care for patients. It started in the emergency department, and then with some really important collaborators thinking that, while we like to think in the emergency department, that's the whole world, we're very mindful that that's a very small portion that patients interact with. And really, how can we partner in the outpatient setting with you all and your experience in different roles with the pre-hospital providers? And so this is looking at some of our experience looking at patients in the pre-hospital setting with EMS through the emergency departments, and then linkage into follow-up care for patients that we're seeing for overdose, for patients that are in the emergency department with opiate use disorder, and a little bit of what our ideal and hopeful future state will be. And so, sometimes it's helpful to start with a case like we just had, or to think about in your recent interactions, just patients who are interacting with this system in different ways. And while a lot of this work started in the emergency department, we're going to start from the pre-hospital setting. And really some important collaborators that I mentioned. Dr. Megan Gussick is another emergency medicine and EMS physician, and is the medical director of Madison Fire, and really has been the champion of a lot of this pre-hospital work that we'll talk about. Dr. Elizabeth Salisbury Offshar, a number of you know, is an incredible mentor in addiction medicine, and has really been a champion in the emergency department, and be highlighting um, some of her work in the outpatient space. And then Michelle Orellana Lopez is an excellent phase 2 medical student who worked on a lot of this pre-hospital work this past summer as well too. And so, this needs no introduction to this group, but really this has been a paradigm for engaging our paramedics, engaging our folks within the emergency department, of looking kind of beyond a single encounter at the chain of survival for drug overdose, and really what the ideal state within where we're working in Dane County and Madison, within slightly smaller UW system. And still, that while these deaths by overdose numbers over the past couple of years, through a lot of work of a lot of people, are improving, there's still a lot way to go. And really, this is where I find the most compelling case for my teams in the emergency department is, within our area, the frequency of emergency department encounters, the frequency of EMS encounters before patients die by overdose is really high. And so having systems in place that uh, function to help address patients who present for overdose every encounter is really significant. And so we'll start a bit with the pre-hospital or in the field standpoint. And this is something over the past couple of years that has really been shown to be safe and effective. And some of the original work came out of Oakland and the Bay Area and Camden, New Jersey, and really was replicated and by our EMS workers here, that it's been safe, effective, it's within the scope of paramedics. Some of the original studies, pretty minimal adverse events. And, with everything we do, regardless of the field, we have to make sure we know what the cost is. And that's especially true in EMS, with scene time really being the biggest currency. And so, how much time does it take a crew off the street that can't be at another call? And again, some of the original work was really this entire process of ability to initiate buprenorphine in the field had a pretty minimal increase in scene time, with a lot of benefit. And so more engagement in treatment and follow-up, both in 37 days and 30 days, again, in some of the original studies. And so what we care about here a little bit more locally, and we're just over 2 years now post implementation of Madison Fire. Both their cares paramedics as well as all Madison Fire ambulances carry buprenorphine. And some of the initial training, looked at just what this medication is, understanding physiology of overdose, understanding opiate use disorder and the benefits based on some of the prior studies and data. And so we have incredibly skilled paramedics, but some of just the pharmacology of buprenorphine would not be something that's covered routinely in their paramedic programs. And this is a campaign or a sheet of campaign to local emergency departments. And so within the areas that Madison Fire serves, there's two UW Health emergency departments, as well as St. Mary's and Meriter. So a number of partners across different health systems with different clinicians receiving these patients. And so this, again, led by Dr. Gussick, was a lot of work of talking about this to the teams and then working with the protocols of who receives these medications. So kind of two big camps: person who is experiencing withdrawal after self-cessation of opioids, or is in who just received an opiate reversal and is in acute withdrawal. And so in a simplified graphic, this is really what the paramedics are working off of a COWS score, an initial buprenorphine dose of 16 milligrams, and then emergency department transport or follow-up. And that's really a big piece. And ideally, we want to have a system in place for follow-up should patients want to be transported to the emergency department or not. And so ideally transport to any of the local emergency departments. This means that there's a next step, prescription, ongoing treatment, evaluation is appropriate, and prescription upon discharge, as indicated. And if patients decline transport, the Madison Fire Community paramedics make follow-up calls as well and receive this handout or this information about some important next steps that's also easy to understand and some places to go. And we'll highlight the Compass program later in this talk as one of the locations to be able to connect patients from our emergency department to next steps if they don't otherwise have a primary care provider or a main sort of healthcare location to go. And so again, just over 2 years, here's some of the data through the first quarter of this year. So 39 times buprenorphine administered 39 times by Madison Fire. And some of that information here of average age. We'll look at the range of COWS scores here shortly, but median COWS score of 16. And then from being in the emergency department, a high transport rate, which I think for evaluation, diagnostics, next steps, and time is really excellent to see out of this. And so some of the things we were interested in is why these patients were in withdrawal. Again, this is from the paramedics. So a good portion, 40%, were from they had received naloxone post overdose. And so we dug into that a bit. Some self-cessation, prescription lapse, or as well as some calls from patients or facilities where patients were incarcerated and had withdrawal. Kind of zooming in on that naloxone first bar, we were interested in if who gave this, if this was EMS, if this was law enforcement, and a number of bystanders were the ones that administered naloxone. Again, a wide range of COW scores, but median of 16, and so some significant degree of withdrawal. Again, looking at the paramedics to be able to accurately score and initiate this treatment. And so, as with any program evaluation, we have some initial numbers, and we're wondering where to go from here. You may have highlighted there's a couple of administrations per quarter for the last few quarters, and just to be able to understand what's going well, what we can improve on. And so developed a survey tool, interviewed 9 Madison Fire paramedics across a number of experience levels or duration of time with Madison Fire, and really looked at a lot of practical things, training, comfort, what the scene looks like in their experience talking to patients about buprenorphine, um, and then what our opportunities are, sharing success stories, the patient interest, and perceived barriers. And so, um, surveying 43 responses from our paramedics. Most were comfortable, most thought this was a good idea, and some really kind of interesting um, barriers. One, like with everything, and certainly with EMS, limited time on scene, and law enforcement presence was something that came up a lot. And oftentimes, calls for overdose will come through dispatch at, I think, very appropriately is really the highest level. And so despite, kind of highest level of alert. So oftentimes law enforcement may be the first on scene, despite, real short response times from EMS. And that has a huge factor in just the scene dynamics, especially for patients experiencing overdose or then acute withdrawal. Think some opportunities for education, next steps. What do we do if patients decline transport? Again, the numbers we have so far, it's been relatively few. And so there was some discomfort about what happens in these, specific situations. Um, and so up to this point, really, I think the paramedics were very comfortable calculating the cow score when indicated, and that the field buprenorphine is really a good it's a good addition within our area for this chain of survival. Some big things from the survey responses and next steps that we're doing is, creating is a lot of coaching around these conversations for paramedics. So as you all know, the time frame, especially in acute withdrawal, to be able to, it's hard to explain to someone whether they're familiar or not that this medication may help you feel more comfortable, compounded by the fact of just the pre-hospital environment, law enforcement, bystanders may or may not be present. It's a short period of time to gain a lot of trust, especially if someone has not been familiar with this medication as well. And then I think an opportunity for law enforcement collaboration and for resources for patients who don't want to be transported. So that's really been the newest area of evaluation. We've spent some time in previous years, but if patients are coming to the emergency department, really within emergency medicine residency training with our professional societies, this is really the standard of care. And so I'll just briefly go through that our experience at UW Health going back to 2022, which is, sort of everyone thought this was a good idea. We looked at nurses, our social work capacity, our residents, as well as our faculty physicians, both around attitudes, barriers, as others have done for ED buprenorphine initiation, overdose education, naloxone. A big factor was a lot of time, and so we've now for the past few years have had again with collaboration of the addiction medicine colleagues. An uncomplicated opioid withdrawal clinical pathway in the ED, and this is exactly what this screenshots from this pathway of ability to initiate buprenorphine in the ED, to be able to send follow-up for patients that are not in active withdrawal but are still interested. It has information on the bottom for what a home induction would look like, and this has really been a process of iterating, continuous process improvement, ongoing education, especially in departments where we have new residents every year, new learners, growing faculty. And so one thing we found early on was that we had a big opportunity for naloxone co-prescribing that was being missed. And so a number of interventions, um, a number of which was not directly involved, but happy to have going on things like the Dane County Emergency Management support for harm reduction vending machines. We uh, worked with Wissam, Dr. Bhatnagar, a number of folks on overdose response kits in our emergency departments, which had been incredible resource for patients, many of whom were not coming in with a primary concern of overdose, but being able to kind of continue to get naloxone into the hands of people who want them, as well as supporting really targeted education to our nurses and providers. And so through a lot of these things, we kind of resurveyed our clinicians this past summer, both physicians, our PAs, residents, and really through a number of these interventions, folks felt more comfortable prescribing, that there's more in the emergency department we can do. And that has really been our goal with a number of these interventions. And so I think the biggest next steps and opportunity is continuing to partner for what is the ideal state for patients leaving the emergency department, whether that's on with a new prescription of buprenorphine, whether that's following overdose or not. And this is highlighting some of Dr. Salisbury Offshore's work in the Compass program to be able to provide walk-in services with a uh, wide variety of walk-in services, excuse me. And so we think about kind of ongoing challenges just broadly across the healthcare system with access, as well as co-occurring medical conditions like wound care, reproductive health care as well too. And so right now the Compass program has walk-in availability with this structure, intake, medical needs. And from the emergency department, we're fortunate to be able to direct patients there during their walk-in times for follow-up. And they're really getting referrals from a number of different sources, our emergency departments, jail, law enforcement, and from a lot of prior patients as well too. And then to be able to continue linking to these further community programs as well, and that it's additional supplies, and we're taking a lot of this information back to the emergency department as well too of what we can provide patients. And so really next steps broadly across pre-hospital emergency department, and our emergency department ability to connect within the outpatient setting. Dr. Gussick just actually earlier this week had the most recent Madison Fire Education Days, really sharing a lot of these data with our paramedics as well, working toward more system-based solutions for referrals to Compass program's ability to connect with peer support specialists, and then looking for ongoing quality improvement. And really the exciting piece to share of this that Dr. Salisbury Offshore is leading and participating in as well too is a grant funding this past fall over the next 4 years to really develop this overdose prevention and treatment research network, looking across the continuum of care and connection to follow up into the community. And so this is really our future state, building on what we've done so far, which is uh, identifying patients that are at risk for opioid use disorder in the emergency department, or, for example, that may come in following an overdose, improving our existing pathways that we've highlighted, and then really being able to connect both through the AHR, EHR to the Compass program for follow-up, and with discussion with patients, sort of direct linkage and engagement with peer support in the emergency department and follow up as well too. So leveraging a lot of technology for in the ED for follow up as well. And so we've been working with community advisory board on this, as well as a number of folks across the health system, to really make sure that linkage to care, because so much of this we know goes well beyond the emergency department, is in place. And so again, through these ongoing efforts, both in started in the emergency department, expanding access to outpatient as well as with Madison Fire, and I continue to hope to improve our ability to care for patients following overdose and with opioid use disorder in Madison and in Dane County. And so I've left a couple of minutes for questions, but I really appreciate your time and for the opportunity to be here. Thank you.